We have a session on M-Health, and I sure hope everybody understands what M-Health is all about. Well, it's actually an abbreviation for mobile health, and it is a term that describes the use of technology within the health sector. Most people will associate M-Health, mobile health, with the phone, but it is actually much more than that. You can actually talk of your personal digital assistants, your PDAs, your smartphones, your laptops, whatever. But really, we are seeing that there are lots and lots of applications that are being developed under mobile health. And today, we are lucky in that we have 2 organizations that have already used these applications for as you'll see from their presentations, greater access to health services, and also making sure that we have greater access to information. So I will call upon our first presenter. Our first presenter is Karen. Karen is from OPHID, and I'll ask her to give a little bit more background into the work that she's been doing. And our second presenter is Jabulani. Jabulani is also with SAFAIDS. Please, can you also just give a brief background of the work that you've been doing around M-Health? We'll have 2 presentations, and then the 2 presentations, one after each other, and then we'll have a discussion. So I'll call upon Karen to come and give the first presentation.
So today I'm very happy to be here to describe to you the results from a process evaluation that we did together with Unicef and with CCOR on M-Health for strengthening communication across the early infant diagnosis results chain. So I'll talk to you about the usage patterns, facilitators and barriers to the use of mobile technology, and in this case we mean cell phones. When we're using mobile technology, we'll get right down to the core issue, the use of cell phones by rural healthcare workers. So just as a very brief overview of early infant diagnosis and why it's an issue, we know that in the absence of timely EID, 1/3 of infants will die before, HIV-infected infants will die before their first birthday, and half of all HIV-infected infants will die before their second birthday. So obviously timely EID is of great importance. For this reason, HIV testing is done amongst HIV-exposed infants at 6 weeks after delivery by DNA PCR, and then subsequently amongst breastfed infants at 9 months, and then again 6 weeks after cessation of breastfeeding. And in terms of early infant diagnosis in Zimbabwe, with an HIV prevalence in ANC, estimated HIV prevalence of 15.9%, our early infant diagnosis timely EID is not that great. It's difficult to determine in the way that we collect our indicator data, but estimates have it as low as 45% of infants, our HIV-exposed infants, are tested before 6 weeks. The PMTCT stocktake report for 2013 indicated that the overall turnaround time from specimen collection to EID results, so now we've got the child in care, we've tested them, now what is the turnaround time to receiving those results and acting appropriately, was 15.9 weeks. So obviously, given the urgency of EID, this is much too long. And that the longest delay in turnaround time involved from moving the results from the time it reached the clinic to the caregiver of that infant, with a median time of approximately 6 weeks. So within this program context and national context, OPHID Trust, together with Unicef funding, implemented the prevention and treatment of HIV in undernutrition in infants program in 2 districts of Zimbabwe, and that was Marondera and Wedza district of Mashonaland East, as indicated on the map. And within these districts, one of the key outcomes that we were after was to increase timely EID. So to support that, healthcare workers were saying, well, we're having a lot of problems in communicating up the chain and following up about where is the specimen, where are the results, communicating with village healthcare workers when notification results were ready. So in October 2011, dedicated cell phones were provided to the 32 health sites being supported by the project. And that the purpose of these was to improve communication across the EID results chain. So this diagram is just to start to acquaint ourselves with the players in the EID results chain. These move from the patient or caregiver of the exposed infant through to village healthcare workers, who are our linkage between communities and facilities, as we're all very familiar with in Zimbabwe, to the rural health facility itself, and then higher levels, which include district levels, and then of course NMRL and research laboratories. So there's movement across, between, and within these systems. So it's not as clear-cut as we might think. So within this context of providing cell phones to health facilities to improve communication across this results chain, we needed a process evaluation to understand what happened, how were they used, and what were the perceptions of those that were involved. So our overall goal was to identify the strengths and missed opportunities where activities within our pilot program that provided cell phones to health care sites could be leveraged to further improve information flow and provide recommendations to Unicef based on these. So our three key objectives for this evaluation were to describe cell phone use by healthcare workers. I mean, how were these cell phones used in the first place? It's a very important first step to understanding the communication chain. What are the facilitators and barriers experienced by rural healthcare workers to the use of cell phone technology? And then finally, to generate formative evidence regarding feasibility of expanding access of cell phone technology to community levels. Within this project, we were only supported to provide cell phones to health sites, but we wanted to understand, and this, given the time period, now this seems, it's amazing how quickly things move on, but this was 2013, and now sitting in 2015, we all know that there's been progress, and we'll hear about some of that today from SAFAIDS. I'll briefly run through the methods and procedures. This was a qualitative descriptive study. Because we were interviewing and surveying village healthcare workers, we received MRCZ approvals. It was a purposive sampling, not randomized sampling, in that it was a project-driven approach. We sampled all the sites that were being supported by the project, but it was inclusive of the population in that we tried to sample all village healthcare workers in all sites being supported. And then from January to September 2013, we collected routine monitoring data and analyzed this. And then from August to December 2013, we conducted survey work using structured questionnaires with both sites and village healthcare workers, and then also focus group discussions to try and interrogate and receive some depth to the information we received through the survey. So let's get to the good part, the results and the interesting bit. I'll present the results in terms of our three major objectives. And because we don't have a lot of time today, I'll coincide the results with some of the key discussion points that we felt were raised from the key results of this survey. So from the first objective, we'll talk about how cell phones were used, and then facilitators and barriers, and then the feasibility of expanding mHealth to community levels. So first, how did we use cell phones? How were cell phones being used at health sites? As part of our general operating procedures questionnaire, we asked sites, what other forms of communication do you have available to you? And quite strikingly, we can see that for almost all sites, the only functioning means of communication at that time in 2013, so compared to now, were cell phones. This both through the OPHID Unicef project cell phones and through the RDNS disease surveillance cell phones. Moving on to the general operating procedures, how were cell phones being used, what systems were in place to support cell phone use. At the vast majority of sites, 72%, there were no general operating procedures in place about storage, about who used it, how it was used, confidentiality issues. At over half of the sites, 52%, the cell phone was kept at the most senior person on duty at the time at the health facility and accessible largely only by that person. and that 93% reported that the $10 that was provided in airtime per month wasn't sufficient. And the majority reported running out of airtime from halfway, basically, through the month, through to the end of the month. And then finally, for the utilization monitoring, we experienced some problems with consistent reporting. And this was mostly felt at high volume sites. So the recording of when the cell phone was used, how it was used. And so we had to exclude 5 sites from the analysis because we felt it would skew the data in terms of how cell phones were being utilized. So the rest of the results for utilization are based on 27 of the 32 sites. So among these 27 sites, there were 3,597 calls made over a 9-month period, with a mean of about 15 calls per month, and then of course the range is based on site volume between 2 and 64 calls per month. The nurse was recorded as the caller for 99% of all calls made, so pretty much the entire time nurses were making the calls. And that of interest, I think surprised us, that voice calls were not made in 98% of calls made. We expected to find more text messages within the utilization. And that the majority of the calls, 64%, were made from rural health sites to higher level, so either district, provincial, national labs, or higher. And that in the person being called by the healthcare worker, so by the nurse is making this call, who is she calling? It's a fellow healthcare worker in the majority of times, by 56%, so just over half. So this displays the proportion of all cell contacts made by location, and we see that it splits into roughly a third by district, provincial, and village level. So we had the communication chain, our results communication chain, and we were looking to see who do we need to contact most? Well, I think this says a lot in terms of, while higher level contacts were made most frequently in an aggregate way, 1/3 of contacts were made to community level. And then what reasons? What were the reasons recorded for the calls? This is important to understand how we can optimize and what the most important communication needs are of rural healthcare workers. And you'll notice, other was the most frequently cited reason for calls. But then of course we had an open-ended, what was your other? Please list it. And because we had designed the tool to record communication made for the EID results chain, our list of potential options wasn't exhaustive. And we found that healthcare workers cited surveillance reporting, follow-up procedural inquiries, like should I do this, how do I do this with higher levels, or arranging meetings with village healthcare workers in health center committees, which are all crucial activities of rural health sites, as the main reasons as their calls, followed by follow-up of missed appointments. Now, in terms of the location of person called and reason for contact, this is quite a busy graph, and I don't want you to try and assimilate all the information on this graph at once. But what we felt was important was that while the aggregate data indicated that higher level healthcare sites and healthcare workers were the most frequently combined reason for a call, when we looked at the granularity of this and the individual reasons, the location and person called, it was at village level and follow-up for missed appointments. So village is really, for the follow-up at missed appointments is the greatest single reason that calls were made. You can see 556, it's quite compelling. So then we move on to objective 2. Now we have a sense of how the cell phones were used, and now we want to understand what were the facilitators and barriers to cell phone use. Well, 69% reported it wasn't all plain sailing. Almost 70% of sites reported that there were barriers, that they did face challenges to the use of cell phones. But that we'll see that the most frequently cited barrier was power for recharging. And I think we all understanding the rural context, this makes perfect sense. And then when we asked in terms of, so what were your barriers for communicating along the EID results chain? Where do you face your greatest challenges as healthcare workers in ensuring that HIV-exposed infants receive their results and are tested? Now this shows that 30% of health sites, so the N's here are health facilities. This was in our general operating procedures questionnaire. 30% of sites felt that the greatest challenge was faced from contacting village healthcare workers about missed appointments, follow-up of results for notification, but that the majority felt that the greatest challenge in communication was reaching the caregivers of those infants. So that across the board, 76% felt that the greatest communication barrier was held at community level. So I think this gives us a good idea of where we can invest our resources for communicating. So then, always to pair things off, what are the facilitators? How can we improve things? Healthcare workers felt that the use of cell phones could most certainly be improved by the implementation of standardized operating procedures. So a lot of things that came out in FGDs is that healthcare workers were unsure. Can I contact a patient? What information can I give in a text? How is this? So standard operating procedures for communicating were listed as, and the conditions of use for cell phone use were highlighted as ways that they could improve their use of cell phones. And that critically, as we've seen through who they contacted, was to expand the formal support of cell phone use to the community level. And then, of course, solar chargers to overcome their barrier of recharging the phones. So a big question that we had with the reference group, the CCOR reference group, was how are we going to monitor cell phone use? We put these cell phones in these sites. How are we going to monitor how they are used? And these were some quite compelling comments made during focus group discussions. One healthcare worker said, "It's not easy, especially at large centers with many staff. Accountability is difficult. We have so much to do, we cannot spend all of our time monitoring cell phone use." So I think if we're going to continue on with these communication methods and expand and expect accountability within our programs, we also have to weigh that against supporting our healthcare workers and not overburdening them with filling out forms, more forms. And then moving on to our objective 3, the community level mHealth. So this involved doing an access questionnaire with 486 village healthcare workers that resided in the 2 districts of our project. And we asked them, how many of you have access to a cell phone? Well, it's quite compelling in that the vast majority, 9, almost near universal access among village healthcare workers to cell phones. And the vast majority had a personal cell phone. So it's a completely viable approach to work with village healthcare workers, as we'll see. And then, while the barriers to cell phone use noted by village healthcare workers in the access questionnaire largely mirrored those of the rural healthcare sites, which makes sense, power for recharging, village healthcare workers definitely faced greater barriers to accessing airtime because they are more at the village level, with 35% only being able to access airtime once per month. So any programs that were resulting from this and in supporting village healthcare workers would have to somehow be providing them with airtime in a more frequent manner. So looking at the big picture, how did cell phones improve, impact, without doing an impact analysis at each stage of the communication, which monitoring utilization data made impossible? What were the perceptions and what did the data tell us about how cell phones impacted communication? Healthcare workers described cell phones unanimously improving efficiencies at health sites. Sample transportation, they were able to follow up. Where are you? I've got a sample that needs to get there. Previous to this, they had been beholden on runners, runners between site levels. It made results notification faster, perceived, and then reduced turnaround time due to this less legwork required. It reduced workload on healthcare worker perceptions, and then also improved planning and communication between levels. And I think this is our other that we saw. It's when's the meeting, who's coming, how do we do this? Those types of communications impact entire systems. And then another thing that came out that I thought was quite important was improved relationships were described. If miscommunication creates sometimes conflict and tension. And so improved communication was felt to improve the working relationships from rural healthcare workers with village healthcare workers. And then from the village healthcare worker perspective, in terms of how cell phones support their work, a village healthcare worker at Border Church said, wherever I am at all times of day, the cell phone is available. So that's both for their clients and from the health facility. So just to keep also our eye on this whole thing was to improve communication across the EID results chain. Not to think that cell phones are going to be the panacea for EID. It's not going to answer all of the problems. When we asked healthcare workers, what is the greatest challenge to successful EID? It wasn't cell phone communications. It was having your child agree to be tested in the first place. So while cell phones and mHealth can support the process, it's also to underscore that there are larger community-based things happening that we need to attend to. So distilling a lot of information into some few recommendations resulting from this process evaluation. We felt that at policy level, given that cell phones were the only functioning means of communication, that this warrants and justifies government investment in cell phones for health communications, that rather than rehabilitating landlines, that we can actually invest in the use of cell phones. That the strategic capacitation of health system frameworks for the use of mHealth at community level, so bridging it all together rather than doing it in silos, health facility, district, labs, that we can create systems and frameworks for cell phone use. And that finally, formalizing public-private partnerships is going to be key to moving forward in terms of utilization monitoring, in terms of technology development, solar charges, all of this will rest. This isn't our mandate as humanitarians generally, our public health professionals, but that's the private industry. And then finally, at the health systems and program level, I think we could all see that there's a need for standard operating procedures on the use of cell phone technology to support healthcare workers to utilize this in the most efficient and effective way. And that in particular, text messaging could be increased and optimized. And then community level, I think there's great evidence, and we look forward to hearing about how extending mHealth to community level can be valuable, and that mHealth should not replace community engagement, that there's still household level support that's going to be required. In terms of research, this was a process evaluation. It wasn't a rigorous randomized, cluster randomized control trial. So there's room to understand how mHealth can improve turnaround time across the cascade. We should have a better understanding of the cost effectiveness implications of use of mHealth technologies, time and motion studies, feasibility and acceptability of patient-level mHealth, so sending texts to patients and communicating directly, and then of course understanding what are the barriers to EID by mothers and caregivers of HIV-exposed infants. So I think we've gone through the conclusion from the main points, and just as a parting thought, I'd like to thank very much the Ministry of Health and Child Care for their support. Particularly to Unicef Zimbabwe and CCOR, the CCOR reference group who supported the design every step of this process, PEPFAR through USAID, and then of course the healthcare workers and village healthcare workers who participated in this evaluation. Thank you.
Thank you, Karen. Just to remind everyone here, this is a live recording and we're already getting comments and questions via Skype, and we are really taking advantage of the technology. Please just note down your questions. We'll have the second presentation, and this is coming from Jabulani. Jabulani is with SAFAIDS.
What I'm going to present is, we are just building on what Karen has presented, and it's basically a pilot project that we introduced in Masvingo, and specifically Chile district. And this was in support of the initiatives by the Ministry of Health to ensure that there is retention of clients. And this program specifically, we are doing it in partnership with the OPHID. We have just presented a similar presentation, and they are the lead in that consortium, which is called the FACE program. And like I've already indicated, what I'm going to present is the finding from a pilot project that was done over a period of 7 months. And in terms of the background, why we introduced this initiative, I will present that in form of the objectives of this initiative, which basically the main aim of this initiative was to strengthen linkages between the communities and health facilities. In a way, trying to address the gaps that we identified on a paper-based referral system. So this one is still a referral system, but it came in to strengthen the referral system because in our programs we are mainly using the paper-based referral system, but there were gaps that we observed, and then we decided to introduce the use of mobile phones in terms of trying to address those gaps. And the specific objectives, again, the program that we are implementing with the consortium partners is basically to ensure that there is increased retention of mothers, infants, and families, particularly in issues of HIV prevention, care, and treatment services. And also to make sure that there is that increased uptake, which is again the enrollment in that cascade. And the third key objective was to make sure that we were trying to improve the quality of data that was being generated and reported by the village health workers, who are the collectors of the information at community level. And the expected outcomes when we introduced this pilot project, what we wanted to see, the number one outcome was to see an increased number of clients being referred, identified in the communities and referred for these specific services, which is pillar number one of enrollment. And then after that, we just wanted also not only to refer clients, but to track if these clients are then accessing the services that they are being referred for. And thirdly, we wanted to see improved adherence to appointment dates. And this also, I think, from the presentation from Karen, she also highlighted issues of missing appointment dates. So this was also another key outcome of this pilot exercise. And the fourth one, which also speaks to one of the objectives, the issue of retaining clients in the continuum of care. So in terms of where this happened, like I indicated, it happened in Chibi district, and specifically at 4 facilities, which are Ngundu, Tagawara, Shaburanda, and Zimbabwe. And also for us to be able to see, to demonstrate the effectiveness of this initiative, we also had a control site in the same district by the name of Tishan Clinic. And these are some of the information in terms of the number of village health workers that we went with. At Ngundu Clinic, there were 14 village health workers. At Tagawara, we went with the 8 village health workers. Buranda, it was 6, and Zimbabwe, it was 8 of them. In terms of the population, these are the statistics. Now, the overview of the ML, I think for this one, I will explain it diagrammatically. I'll come to this diagram, which is a diagrammatic presentation of how the whole model functions. To start with, normally we pick this area at this point as the entry point, where we have healthcare workers at a health facility who compile the list of clients with appointments and those who are lost in follow-up. So the details of the clients are compiled in an appointment diary, and what we have in that appointment diary is basically the name of the client and the date when the client is supposed to come for an appointment. And this information, once it is captured in this diary, there's a community referral facilitator. This is a volunteer that we are working with. And this cadre is then responsible for collecting or capturing the information from the appointment diaries into the mobile phone that these community referral facilitators received from the project. And that information, once it is captured, they have a list of village health workers where these clients are residing. Once that information is captured in the mobile phone, an SMS is sent to a specific village health worker to say you have to follow up on client A, he or she has an appointment on a specific date. And for purposes of confidentiality, what is sent is basically the name and the date of appointment. There is no specification to say why this client is supposed to come to a facility. And once the village health worker receives that SMS, the next thing is now to follow up with the client, to remind the client of that appointment. And when the village health worker visits a specific client, he or she captures the information of the client on the mobile phone, and that information is automatically uploaded on an mHealth portal, which is a web-based database. And that information, for people who have access rights, they're able to see the specific client, when the client was referred, and when this client is in appointment. So in terms of access, basically in this project, it is SAFAIDS, OPHID, and the Ministry of Health, so that we are able to see that this specific client was followed up and what happened to that client. And these are the key players in this pilot project with the district health information team, SAFAIDS, and we have an implementing partner by the name of BASO. And these cadres, they normally routinely provide technical assistance to both healthcare workers, community referral facilitators, and also the village health workers. Now coming to the results, and for this one again, we are showing the results of the paper-based and the results of the mHealth. And what we did when we introduced this initiative, we collected baseline information at the 4 health facilities. And the baseline period was April 2014 to July 2014. And the implementation period for the mHealth was September 2014 until March 2015. So the results that I'm going to present, you will see that there will be this distinction between the paper-based and the mHealth. Looking at the referral identification of clients at community level, this is what happened. What we have in this graph, we have this left panel, which is the paper-based, and then this right panel, which is the mHealth referral system. And what we are seeing here, during the paper-based, the maximum number of clients that were identified by village health workers at community level and referred, the maximum was 193. And when mHealth was introduced in September 2014, there was an immediate jump in number of clients that were followed up or even identified for specific health services to 320. We saw an increase again in October 2014, and there was a downward trend. And specifically during this period, it was because of the holidays and also the farming season. But immediately after that, the number started to peak, and in March we had 599 individuals that were identified, and some of them being followed up in terms of those who had appointments. Now the previous graph, it shows everyone. Some of them, they were just identified for other elements, but for the purposes of this pilot, the major thing was to say for those who have been lost to follow up, how many of them have been followed up, and those who had appointments, how many were followed up. And what we noticed is, during this period of paper-based, basically again the issue of data quality, it was really difficult to identify or to prove that there was a referral around issues of follow-ups, except through the cellular data at health facilities. But at community level, the village health workers, they were not able to demonstrate this. But immediately after the introduction of mHealth, we were able to see significant numbers. And what we are seeing in September, the blue bar, is for adults that had defaulted, who were followed up, 35 of them, and for the infants, it was 14 of them. And interestingly, the trend that we observed throughout the 7 months, we noticed that the number of clients that were followed up because of defaulting, it was gradually declining. And this, to some extent, it was because of the introduction of mHealth. There was that effective follow-up of clients by the village health workers. And again, through the key informal interviews that we did with the village health workers and the community referral facilitators, it was something that they mentioned to say there is now increased linkage between the health facility and the communities, so that the follow-up of the clients with the appointments is significantly improved. And looking at this other variable, which we can call an indicator, which is about clients who had appointments, who were followed up. Again, a similar trend before the introduction of mHealth was observed. And soon after the introduction of the mobile phones that were used for tracking and following up of clients, we started to see significant numbers going up, and in March, we had as many as 91 clients that were followed up who had appointments. And what was coming out, one of the reasons why we had this kind of trend, it was specifically mentioned that through the introduction of mHealth, the village health workers are motivated and they have that zeal to follow up on clients. And also the other thing that was coming out from the clients themselves, it was to say, for them, they believed in the technology. The moment they saw someone capturing their names in a phone, they trusted the system. And because of that, they were able to see more clients. And as we will see in the coming slides, we see that even in terms of the clients that were identified and fed and then accessed the services, it was significantly better during the time of mHealth implementation. And this is the graph that I already started talking to in terms of, we wanted to know, to say, of those individuals that were followed up and fed, what proportion of those individuals then reported for access. And through mHealth, through that portal which I talked about, we are able to track to say client A was seen on this particular day, and this same client A accessed the service on this particular day. We are able to track that client. And what we are seeing in this graph, prior to mHealth introduction, the period April to July, we are seeing that the proportion of clients who were followed up or that were identified at community level and referred for services, it basically ranged from 22% to a maximum of 27%. And immediately after the introduction of the mobile system, the number increased to 44%, and in December we had 90%. And this huge jump for December, it can also be linked to the smaller number of clients that were identified and referred. So in terms of the denominator, it was significantly low. And the trend, basically, as we are seeing, during the mHealth implementation period, the proportion was consistently higher than the proportion that we observed prior to mHealth introduction. And again, the reason being that, like I indicated, the motivation on village health workers to follow up on clients, and also the confidence that these clients had. And again, what is happening through mHealth, because we are able to monitor the individuals that are referred, someone can go to that portal and see the names and be able to follow up with the village health worker to say, you have a client A in your community. You need again to follow up to demand that the appointment date is for tomorrow. So this really showed some positive results in that regard. We then further went on to say that previous graph, it was including again everyone. We then deep dived to say we want specific indicators to do with those lost to follow up and also those who had appointments. Because the other graph, it also some of the individuals, they were referred for TB because they were just identified in the communities. But now specifically looking at the issues of follow-ups and appointments, this is the trend that we observed during the period of mHealth implementation. Again, prior to mHealth implementation, the issue of data quality again, it was really compromised. But the introduction of mHealth, we are seeing significant in terms of the quality of data, and also the trend around those who were followed up after defaulting, who then went to health facilities for the various services that they were supposed to get from these clinics. And this September, the percentage was significantly low because this was more like starting, and we saw that this improved, except for December there was this decline again, but the other subsequent months it was consistently 70% and above, which was not the case with the paper-based system. That was for children, and now coming to adults, because we separated the infants and the adults we had defaulted. And what we observed generally, it was that for adults, in terms of accessing the services after follow-up, it was they performed better, they fared better than the infants. And the explanation that came from that situation is that some of the infants, they are being taken care by not necessarily their parents. And because of that, sometimes these caregivers, they don't really take, or they don't have time, they don't commit themselves to take the infants to the health facilities. And in some cases, it was noted that some of the caregivers are elderly. So there's that challenge of them taking the children to the health facilities. But for adults, it was consistently encouraging in terms of those who were followed up and honored on their appointments. We also looked at specifically, because the project itself is about elimination of pediatric HIV. There was also an interest to say for the infants that were 2 years and below at the time of this assessment, who were delivered at home, and they referred to go to health facilities for issues of HIV testing and so on. It was consistently positive that the majority of them, if not all of them, they finally went to health facilities for the services. And again, what was coming out significantly is that issues of home delivery, they are now low, and I think the statistics is also confirming that. And because of the low numbers, I think that's the other contributing factor that why we are seeing these high proportions of individuals identified, referred, and reporting access in terms of infants. Now coming to the issue of adherence to appointment dates. Okay, adherence to appointment dates. What we were also interested, this information was basically coming from records at facility level. Prior to mHealth introduction, the blue bar, that's the baseline information. What was happening at Mbundu, for the period that we assessed, we realized that 60% of individuals that had appointments reported access to services, and this increased to 70% during the period of mHealth implementation. And this was more like similar across the 4 mHealth intervention facilities, and also the control side. But the margin at this control side, it was significantly lower compared to the other 4 sites. That was for adults, and we did a similar analysis for the infants. And again, the proportions compared to the adults, they were fairly lower, and I think the explanation is similar to what I talked about before. The other critical thing that we observed that improved because of the use of the mobile phones, the reporting or the activeness of village health workers, again because of that motivation, of that encouragement. Prior to mHealth introduction, basically for those 36 village health workers that we worked with, because we were already working with them prior to mHealth introduction, It was the range, it was 20% up to 50%, and this increased to 100%. And in March, it was 95% of the 36 village health workers that reported. And those are some of the key lessons that we learned. I think I will just rush to some of the recommendations, which are more or less similar to what Karen shared, especially at policy level. And at the health facility level, what we observed, what needs to happen, is basically the issue of strengthening accuracy and completeness of client records. Because sometimes there is no consistent capturing of client records, and this needs to be improved. Again, the issue of workload for nurses, there's need to look at that to see how best can it be addressed so that the issue of data capturing or record capturing is improved. There's also need to look at integrating mHealth community level with the electronic patient monitoring system, especially for facilities where this is already happening. Community level, there's need to continuously motivate the village health workers through consistent mentoring and supervision. And we are also saying the issue that Karen also mentioned, it is not adequate just to introduce funds and forget about engaging the communities about these issues. They still need to do that. And we feel that there is need to recruit more village health workers so that in terms of coverage, it becomes more effective. Otherwise, currently, like the table I showed, the proportion of the village health workers and the population is quite very small. This is the end of the presentation, and these are the partners that supported the initiative. Thank you.
All right, so thank you to Karen and Jabulani for the presentations. At this point in time, we'll take comments and questions. I think we'll take 3 or 4 at a time and ask the presenters to respond.
My name is Dr. from World Education. Thanks for the presentations. I have just a simple question on the village health worker to whom both presenters mentioned that they were motivated. I would like to know, motivated by just using the technology, or there was something, or an extra incentive, either money given to them to do this work?
I wanted to ask about the communities, sharing data with communities that Karen mentioned. She mentioned that health workers are very keen to share information with the community, say transmission of IDs, results and stuff like that. We have a system that allows health workers to send in information about caregivers who wish to receive results for their clients, for their infants, and we're not getting so many of them sending in that information. I wanted to find out from her if this is maybe because the clients are refusing or are not willing to receive these messages, or is it because there's a disconnect somewhere? Because there is actually some method for them to send this information. It's not quite working the way we expect it to.
One of the challenges that we have with mHealth is that the child caregivers are reluctant to have their kids tested for HIV. What is your organization doing to address that problem? Thank you very much.
My name is Dr. Zmira, the coordinator of the National Microbiology Reference Lab where the early infant diagnosis takes place. My question is also to Karen. You said one of your problems is getting the babies tested. Is it because the mothers are refusing, or what is it?
This study was done in 2013. So I think in terms of mHealth and cell technology, there could be like an aside here where we say how rapidly the face of these things are changing at a national level and within our program. So right now, the Ministry of Health has the frontline system being rolled out where texts are being sent possibly to patient level. At the time that we conducted this wasn't a possibility, and there were real concerns about confidentiality, and so in the interim, some of these things have been worked out. But I think in terms of patients providing their information, there's still a lot of stigma and discrimination that goes unacknowledged when people are looking for ANC and are HIV positive. And certainly within the paper-based records, we often find that the accuracy of patient information provided isn't always there, and that we go to trace individuals and the information that has been provided isn't correct. We can't speculate on why that is without speaking to women themselves, isn't it? I don't think that should be our place, but it indicates need for more research. And I think it speaks to both Miriam from People's College and Dr. Zinuera's comments about why aren't children coming in to be tested, or why might mothers refuse children to be tested. I think this is a vastly understudied area in terms of community-based research, in truly understanding what are the barriers faced by caregivers of HIV-exposed infants to bringing in children for testing. Some of the comments in focus group discussions that came in, there are some very compelling things that are said in terms of mothers who are HIV positive can take medication for themselves, but then aren't permitted by their husbands or mother-in-laws to bring the child in for testing. I think there's a lot of nuances about HIV and stigma that we still need to understand in order to support women to bring their infants in for testing. That's all. It wasn't part of this study, so I don't want to overreach my bounds.
Thanks.
I was not able to go through some of the lessons learned because of time, but basically what came out is that through the use of this technology, they were really motivated, but this is not sufficient. And in terms of whatever incentives, additional incentives were they given, the village health workers, they were not given anything additional except the $15 that they're getting from the government. And we were only able to pay the community referral facilitators at facility level. Those were the individuals who were receiving some monthly allowance of $40. But the village health workers, there was nothing beyond the phones themselves that they were using.
So they only received the phones and training.
Yes.
You didn't give them any airtime or anything.
Oh, in terms of airtime, yes, they were getting the airtime because for voice calls and also for the data bundles. So they were getting $10 per month.
Okay.
$5 for data bundles and $5 for calls.
Okay. In the spirit of the live recording, we've also got a question whilst we're preparing for the second round. The question is, why do you suggest that we should go you suggest that we should capitalize on text messaging, but during your presentation you indicated that most of the health workers would rather or actually use more voice calls than text messaging. So the question is it because it's more of an effective approach? What should we be doing to encourage people to either use the text messaging, or should we be really looking at more innovative approaches to make sure that we go with the voice controls? But that's just a question that you can think about. We'll take the second round.
We've noticed electronic patient monitoring system is quite an ingenious activity. But I wanted to find out, maybe perhaps from Jabu, because you mentioned that the statistics are then uploaded onto a portal and then there's follow-up. I just wanted to find out, do you have any backup system that is in place, just in case the village health workers lose their phones or something else happens to it? Thank you.
They talked about following up on both patients who were clients rather, who were in the appointment register and then defaulters. I just want to know the rationale of following both those just on register and the defaulters.
Of text messages, and on the model, on the M model, I did see where the communication between the village health worker and the patient is, and do they communicate with the same information about just the name and the date of appointment to the patient because of confidentiality issues? Because you said some of the patients, they don't have personal phones. Thank you.
My name is Emmanuel Gasa, the Executive Director of TAF Zimbabwe. My question is particularly on the issue that in these particular communities, you really find people having challenges in terms of distance. To what extent can we signify the uniqueness of mHealth, particularly to the displaced settlements, for example, in areas like Chingwisi, since you were in the Chile community? And to what extent can we use this particular mHealth system to make sure and engage meaningful partnerships on the triple Ps in terms of knowing that the pediatric act for the nation is actually a challenge from 2016 going onwards? To what extent can we engage more meaningful partners to assist the nation? I thank you.
In answer to that, at the time we conducted this, there were no formalized procedures with standard operating procedures for the use of text messaging. So I think the permanence of text can be quite daunting for healthcare workers. If you're sending a text message out and it stays on somebody's phone forever, if there's an error made, then it's quite worrying. So I think in a way that was part of it, and which the frontline system is now, if there's templates and systems, but at the time there were none. So I think that's what we thought. But then maybe in terms of relationships, it's something we have to look at. I think things are evolving so quickly. WhatsApp, all of these Viber, all of these different things that healthcare workers are using them to assist with consults, to assist with all kinds of things. So I think they will lead us in terms of what's the most effective and feasible and acceptable methods. And Jabulani, I think the rest were in your field of expertise.
In terms of the information or patient records, like I indicated, there's a portal which is a database itself. It's an open data source thing, and it's called Open Data Kit. So once the information of a particular client is uploaded there, it's retained. And whatever happens to the phone, you still have that data in that portal. So it's safe and secure in terms of backup. And coming to my brother from Bindura University, the issue of communication between the village health worker and the client. In this pilot phase, we did not directly interface with clients in terms of the communicating directly with them. So what happens via mobile phone? So what happens is when the village health worker receives the message from the health facility to say there's a client who needs to be followed up, maybe it's defaulted or the client has an appointment, then it is the duty of this village health worker now to physically follow up on this client. And the reason why we are promoting the issue of physical visiting is so that there is, even in terms of sharing of information, and once you see this client, this is the only time you are able to capture information on your phone, and that information is uploaded on that portal. And what we are thinking of now, I think because, again, during the pilot, like I indicated, the extension to say let's directly deal when the client was not there. But there is that thinking now to say how best can we make sure that we directly link with the client. And in some cases it was happening, but not according to what we wanted, because the community referral facilitator, he or she would directly call some of the clients. And the other key thing with the community referral facilitators, they are publicly living positive with HIV. So they would directly call some of the people that they already know. When they come to the facilities, they interact with these people. So when they know that there is Chablan who did not come, these community referral facilitators, because of personal relationships, they will call the clients so that they can come for the services. The issue of distances, yeah, it's a big issue, and I think, like I indicated, to say, even in terms of following up related to this question, we worked directly with the village health workers that are already existing. We didn't train more or new village health workers, so we just worked with those who are already trained, and there was that gap to say in terms of geographical coverage, it was too much for them. So really that is another issue that needs to be addressed. But what we're also doing in partnership with the other service providers, we normally go to the field with the organizations like PSI, the Ministry of Health, so that some of the services can be provided at community level. So those are some of the initiatives that have been taken to make sure that the issue of distance is a bit addressed. And there was a question on I didn't get that one clear, the issue from, I think it was somebody from Way. on appointments and defaulters. What was the question?
I said, considering that it is expensive to be doing the voice calls, what is the rationale of following up? People are just on the register, just on appointment, as opposed to following just the defaulters.
Okay.
Because you reported that you're following both people on the register and also the defaulters.
Yeah, I think it was also because of what we were learning, and I think from the study, what Karen presented, the issue of missing appointments, it was also a big issue that they identified. So we wanted to build on these two so that before you default, because once we have more defaulters, it means it happens, it starts way by not adhering or honoring appointments. So we wanted to make sure that it's appointment and then follow up to ROSA, those who are lost in follow up. So those were the two main indicators that we were tracking in this pilot project. Thank you.
All right.
I'm presenting Feed the Future, Zimbabwe Livestock Development Program. My question is directed to Jabulani. I like the presentation, the slide, especially when you compare the baseline with the end line. And there was a significant difference in favor of the end line. I would like to learn from you the sampling procedure which you used, especially the sample size, how you arrived at that sample size. Also to clear my mind whether the differences are not embedded in the sampling procedure. Thank you.
Thank you very much. My name is Matike Wai from Kadoma City Health Department. Thank you for the presenters. I've got a question for Jabulani though. You said we realized that on this, like on the presentation, there was a decline of 44 from maybe up. There was that decline, and you contributed it to holiday, and also you said that was the farming season. Was it the decline from the beneficiaries or the clients, or was it from the village health workers? And what measures did you put in place to correct that? Thank you.
My name is Gladys Modafa. I visit a private clinic. I liked the mHealth presentation. I realized it's very effective in follow-up. I just wanted to know from Jabulani, are there any measures you can put in terms of confidentiality when you interact with the patient? Suppose you were to implement it in a very private clinic.
My name is Dr. Esther Mfunda from Indura University, Health Science Department. My question is centered on the issue of defaulters and those who were committed to come to the clinic after being communicated by the village health workers or the nurse. You mentioned that when you were comparing between the children and the adults, I'm mostly interested in finding out whether you came up with something concerning the difference between attendance or defaulting by sex between males and females, because we have problems when it comes to gender issues and whatever. So could you maybe shed some light on the possibility of defaulters between the two sexes? Thank you.
It's not necessarily the clients that he visited the facility. What that means is that graph, what it tells us is the number of clients that were visited by village health workers to remind them of their appointments or that they've missed, or maybe it was a follow-up because of lost to follow-up. So basically, it's possible that the client himself or herself went to access the services. But for this village health worker to follow up on the client, that was it's the number of the clients followed up by the village health worker. In terms of the sample size, in this end-line assessment, what we used basically, we used the monitoring data, the data from the portal. That's what we used most to analyze in terms of how many were referred. So you find that we did some bit of direct interviews just to explain the numbers that we see in the portal. But otherwise, when we say 6 people reached, it was based on the portal information that we were seeing. And for those where we have percentages, for example, where we said at baseline, there were 60% of clients who are dead to their appointment dates, compared to 70% at end line. This was through the review of registers at facility level. Because what we wanted to see now is to say, okay, sometimes somebody, because what sometimes happens, maybe one of the challenges of this system, for somebody to be captured as to say yes or she is accessed, you still need to prove that by way of a referral slip. You carry a referral slip to show that you were fed. You get to the facility, then that information on the referral slip is the one that is going to be uploaded on the portal to confirm that you accessed a service. In the event that a client doesn't carry that client is missed in the system. So what we then did was to go to the record, the physical records at the facility, to say during this period, so many people in appointments, and so many of them honored those appointments. So that's how we calculated the percentages for adherence prior to mHealth and adherence during mHealth implementation. The other one was on the issue of confidentiality. How are we going to ensure that there is confidentiality on the private clinics? And this one, when we presented this to the ministry, it's something that we really discussed, and for now, I think I will not be able to give really a convincing answer around that. It's something that we are still exploring, those issues of confidentiality. They normally, when you think that you have closed it, there is always something. So it's something that we are still tightening to make sure that it's really tight and there are no leakages around issues of confidentiality. Thank you.
Thank you, Jabulani and Karen. I note that people still have a lot of questions, but unfortunately we have run out of time.